हाँ जी, हाँ।
मैंने आज ज्वाइनिंग बहुत कम लग रही है आज ना
हाँ जी सर, but we'll start in the meanwhile people
हाँ
will join.
वी कैन स्टार्ट
Okay, sir. So good afternoon, everyone. The case series of SAPA case presentation, which will present every month of the last Thursday. So this month, Government Medical College Patiala is presenting a case from Fat to Fit journey under the leadership of Professor and Dr. Baljinder Kaur ma'am. Presenter is Dr. Anshul Mahajan, who is doing pediatric endocrinology fellowship. And I welcome and request our President SAPA 2026 for the welcome address and formally start the meeting. Over to you, sir.
गुड आफ्टरनून एवरीवन वेलकम डॉक्टर बलजिंदर मैम एंड टीम जीएमसी पटियाला and today's case presenter is Dr. Shivam Chopra. He's a pediatric resident in GMC Patiala and Dr. Anshul Rai Gupta. And I welcome also as an expert Dr. Saurabh Uppal. He's a consultant pediatric endocrinologist, Dr. Uppal's Endo Kids Growth Clinic. And I welcome also Dr. Aminder Pal Singh, CBI Director Principal, GMC Patiala. Welcome, sir. We can start, Oxima.
Okay, sir. Thank you. So, ma'am Baljinder wanted to present a few slides before that. Ma'am,
So I think I will not be my internet on the lab is a bit unstable. I'll be speaking the slides.
okay,
Uh,
okay, ma'am. So, no
so
issues.
welcome, Dr. Sibia, sir. So from your side, I'm presenting the slides of our medical college. So Government Medical College Patiala. The college is famous in India as GOMCO, is affiliated to Baba Farid University of Health Sciences, Faridkot, Punjab. The hospital is named after Maharaja Rajendra Singh and its existence is described in the Imperial Gazetteer of India in 1908 as Rajendra Hospital. The hospital is equipped with all the latest equipments to make it ideal for imparting clinical teaching and to undergraduate and postgraduate students. Government Medical College Patiala is the second oldest medical college in state of Punjab, India. It was founded in 1951 to 53 by Patiala and East Punjab States Union, PAPSU government. Rajendra Hospital Patiala with initial bed strength of 100,000 1009 was attached to the college in early 1951. Padma Shri Dr. Kushteva Singh Chest Diseases Hospital with a capacity of 121 beds and primary health centers at Padso, Kolli and Tripudi are attached with this college for teaching purposes. With the current bed strength of 1650 plus and additional 250 plus bedded TB hospital, Rajendra Hospital is one of the largest health institutions in the region. Currently, in the Department of Pediatrics, we have about 140 beds ward with additional 30 bedded NICU, 10 bedded pediatric emergency, and 10 bedded PICU. The present college building was constructed in 1953 for the admissions of 50 MBBS students. Right now, we are training about 250 MBBS students. At present, our principal, director principal is Dr. Raminder Pal Singh Sibia. He is MD Medicine. And our MS is Dr. Vishal Chopra, MD Chest and TB. And there are super specialty departments cardiology, ICCU, urology, pediatric surgery, plastic surgery, neurosurgery, cardiothoracic surgery, ICU, radiation oncology, equipped with state of art true beam linear accelerator, CT simulator, etc. And our Department of Pediatrics right now is like everywhere, we have a separate MCH building. Uh, and we are running a great NICU, a great PICU, pediatric emergency, and our faculty, along with me as professor and head, there is Dr. Harjinder, Dr. Manpreet, Dr. Arun Mahajan, Dr. Surinder, Dr. Tanya Thakkar, Dr. Amandeep, and we've got a pediatrics rheumatology, Dr. Munish Arora, and we've got Dr. Thakur Veer Singh. He's a medical officer and he's DM Nephro in our department. And intensive care fellowship is Dr. Tanya Thakkar. So every year we are inducting seven PGs. Dr. Anshul Mahajan is one of our gold medalists. So followed by the second batch, mm, Dr. Shivam is presenting today. He is also nearly 70% uh, marks person. So over to you, Dr. Anshul, for presenting the case. And followed by that, Dr. Shivam is going to talk about Cushing. Thank you.
Thank you, ma'am, for your wonderful blessings and remarks. Now, I request if Principal Director Bisivya sir is here with us, we request any words of wisdom from him as well. He's a profound speaker and humble person who we met on the rheumatology. If he's here, it's better that we also request him to say something. Sir is here.
Sir, I think he's left or he's not here.
Okay. Okay, then over to Dr. Anshul, and I request the expert for today's meet, Dr. Saurabh Uppal. Wherever you feel that the one-way presentation is very monotonous, keep on uh, asking the question in between, make the presentation an interesting one. What happened that the resident speaks for 1 hour, and then at the end of the session, expert says. So it becomes very monotonous. So please keep on like asking question in between whenever you feel like that there is a room for discussion.
I've already warned him that I am a bad interrupter.
Okay, okay, please do that, ma'am. Yeah, definitely. Yeah. Over to
So
Dr. Anshul. Please start.
Okay. Good afternoon, everyone. I'm presenting the case of Manthan Gadig. He's a 13-year, 6-month-old male child, resident of Cartridge. He presented with the chief complaints of excessive weight gain since last 3 to 4 years with us. History of present illness. Child presented with the above mentioned complaints. Weight gain was gradual in onset, followed by rapid increase in the last 1 year. It was associated with intermittent headache, and it was associated with difficulty in getting from squatting position. There was no history of any visual disturbance or vomiting, no history of any faulty diet consumption, hyperphagia, or any excessive screen time. There was no history of any dry skin or constipation. No history of
Dr.
any.
Anshul, there is some disturbance at your end, and please go a bit slow.
Yes. Uh, I'll repeat. The child had associated with intermittent headache. It was associated with difficulty in getting from squatting position. There was no history of any visual disturbance or vomiting, no history of any faulty diet consumption, hyperphagia, or any excessive screen time. There was no history of any dry skin or constipation, no history of any chronic use of any drug. There was no history of any major medical illness or intracranial surgeries in the past. In the past history, child had a history of fracture of femur in roadside accident at 10 years of age. Birth history dated to child was born via LSCS in view of oligohydramnios. Child was born full term with a birth weight of 2.5 kg. Child died immediately after birth, and there was no history of any NICU admission or neonatal jaundice or hypoglycemia. Antenatal history was positive for that mother had gestational diabetes mellitus during pregnancy. Family history, child was born via non-consanguineous marriage. It was the only child of the parents. History of obesity in both the parents was present. Father was a non-case of type 2 diabetes mellitus. 24-hour dietary recall indicated that the calorie excess was amounting to only 370 kilocalories because the calorie calculated was based on ideal body weight. Ideal body weight is the weight at the 50th percentile for the height. General physical examination. Child was visibly obese and was comfortable in the sitting position. Heart rate was 102 per minute. Respiratory rate was 22 per minute. BP was in between the 95th and 99th centile, amounting to 122 by 84 mmHg on right arm in sitting position. Anthropometry was very indicative. It indicated that child had low height with a higher weight, indicating unlikely nutritional cause. As in likely nutritional causes, the height and weight both are in above centiles. But in other endocrinal or certain syndromic causes, the height and weight are centiles. Similarly, is reflected in Z scores. The weight Z score was 1 point plus 1.84, whereas the height Z score was minus 2.8, which gave an indication and importance of the use of anthropometry in the daily use of pediatric OPD. In
Can
head-to-toe
you,
examination,
Dr. Anshul, can you explain the Z scores again for the first year residents by a
Z
pointer?
Z scores are statistical measures which are independent of the age and sex. Normally, the standard deviation scores which we calculated are different for females and different for males. But the Z scores, they neutralize this gender and gender differentiation and helps in standardization in population. Normally, a Z score of +1 we indicate overweight, whereas above +1 we indicate obese.
All right.
Head-to-toe examination. Head-to-toe examination indicated child had acne, dusky lips and conjunctiva, moon faces, buffalo hump, acanthosis nigricans, bilateral gynecomastia, central obesity, stria on the lower abdomen, and lower extremities were very thin, giving an lemon on stick appearance. SMR, that is sexual maturity rating, indicated A1, P1, T2, T2, indicating testicular volumes were amounting to 2 ml. G1, the gonad were, the patient also thought that it is a micropenis, but it is a Barrett penis. When we calculated the stretched penile length, measured the stretched penile length, it was 3.4 centimeters. When we went for lab investigation, initial CBC revealed HB of 11, TLC of 8900 with DLC indicated neutrophilia. Ionized calcium was lower side of the normal, that is 1.01, with TSH of 0.46. That may be an indicator of central hypothyroidism, as endocrinal causes, as already told, endocrinal causes present with increased weight and low height. But the free T4 was normal. Fasting BSL was 108, indicated impaired fasting glucose. Fasting insulin levels were raised. HOMA score, that is homeostatic model assessment of insulin resistance. It indicates that the amount of insulin resistance which is present in our body. Normally, in prepubertal child, we use the cutoff of 2.5, whereas in pubertal and post-pubertal, we use the cutoff of 4.3. The reason of which is that during the normal puberty, the insulin resistance is increased by 30% in the normal children. HbA1c was 6.1, similarly indicating an impaired glucose tolerance in the body. Lab investigation revealed total lipid profile, total cholesterol were elevated with an elevated LDL levels. HDL and triglycerides were raised, but HDL was normal. SGPT for fatty liver indicated 28 units per liter. LH, FSH, and testo were prepubertal values. In view of the child being short and obese with typical phenotypic features, Cushing's was suspected and workup was done. Serum cortisol levels were 21.5 early morning, that is 8 a.m. sample. ACTH levels were 22 picogram per ml with the normal range of 5 to 10 picogram per ml. Overnight DEXA suppression test. It is a screening test which we usually do in a suspected Cushing's patient. In this test, we give DEXA 1 mg or a 515 microgram per kg per dose at 11 p.m. And then we check the cortisol levels at 8 a.m. Normal expected levels are to be less than 1.8 microgram per deciliter. The reason is when we give a exogenous cortisol, it suppresses the CRH and ACTH levels, suppressing pituitary and hypothalamus, resulting in a low cortisol levels that is less than 1.8 microgram per deciliter. But in this patient, the cortisol was 10.5 and ACTH was 19 picogram per ml. MRI brain. Following the initial investigations, ACTH being more than double of the normal range, alongside elevated cortisol and typical Cushingoid phenotypic feature, MRI brain was ordered. MRI brain revealed a small cystic lesion in the left side of pituitary gland with small eccentric nodule with internal septation suggestive of a cystic microadenoma. Hence, a diagnosis of Cushing's disease was considered. We further ordered DEXA scan to look for low bone mineral density or osteoporosis, which is very common scenario in increased cortisol levels in blood, which revealed total body less head indicated to minus 2.1 Z score. By definition of osteoporosis, we say that Z scores of more than minus 2 along with presence of 2 or more fractures in presence of low impact trauma. But in this case, we had one history of fracture, but that was high impact fracture since it was a roadside accident. So by these values, we can only label the child as low bone mass, not osteoporosis. What's in the ward? Patient was hospitalized, antihypertensions were started, neurosurgery opinion was taken, and surgery was planned. Child was started on tablet thyroxine for central hypothyroidism. Now, there can be two causes of central hypothyroidism in this case. Increased cortisol levels also have an effect on ACTH. Increased cortisol levels have also a negative effect on TSH. It can also suppress TSH, whereas the second probability can be due to a tumor mass compressing the normal corticotroph cell, the thyrotroph cells. Child was taken up for transnasal transsphenoidal pituitary adenoma excision. Post-operatively, child was shifted to ICU and continuous vital monitoring was done. Child was monitored for BP, BSL, serum sodium, and urine output. Normally, whenever we do any neurosurgery, child is prone for triple phase response. This triple phase response occurs in response to ADH levels. Normally, when a neurosurgery is done, inflammation to the vasopressin neurons causes decreased ADH levels, which can result in transient diabetes insipidus. Later on, when necrosis occurs of that cells, it results in SIAD as the preformed ADH is released. Ultimately, if more number of neurons are damaged, it results in permanent DI. In our case, the child developed transient DI, which was noted on day 3. His sodium levels went up to 154 milliequivalent per liter, but it was managed only by increasing the maintenance fluid to 1.5 times. Child was later shifted to ward on post-op day 5 and repeat cortisol was checked at 1 week post-op. It showed morning cortisol levels to be below 1.2 with ACTH levels of less than 7.2 picogram per ml. Histopathology sample was directly indicative of pituitary neuroendocrine tumor, that is pituitary microadenoma, and it was positive for the markers of corticotroph cells, that is ACTH, synaptophysin, AE1 and AE3 was positive in the cells that were extruded out. These are the comparative post-op lab values from first visit versus post-op day 7. We can see the sodium levels are elevated in the first visit, which is 143. The reason of it is that increased cortisol levels impair free water clearance. Hence, there will be increased free water loss and sodium levels will elevate. Child was then continued on oral steroid replacement and oral antihypertensives and was discharged on 8 days of stay and followed up regularly. 2 months post-op, 2 months after the surgery, child developed repeat episodes of headache and his weight was constant with BP on higher side. Serum cortisol levels at 8 am were sent, which came to be 19.1 with the ACTH again raised to 42 picogram per ml. Repeat neurosurgery call was taken and repeat MRI brain showed persistent small microadenoma in the left half of gland. Hence, further plan for revision surgery versus radiotherapy was taken. There are a highly likely chance that when we go for a revision surgery, due to the distorted anatomy and presence of scar tissue, the surgery is more difficult. Hence, patient was taken up for fractionated radiotherapy. Child underwent fractionated radiotherapy. Repeat cortisol levels 3 weeks post-op showed child to be in remission, and subsequently child was put on tablet highs on thyroxine and antihypertensive. Now, one point to be noted is, in general, with the difference between surgery and radiotherapy, take that with surgery we get immediate remission. With radiotherapy, we get a delayed remission. But in this case, as the relapse was detected very early, so the child remitted on even on radiotherapy very quickly. In follow-up, serum cortisol levels with BP monitoring was done and dose of Hyzon and antihypertensives tapered and ultimately stopped. These are the total lab investigations which we did on follow-up visits. On post-op day 7, after the first, the child was in remission, whereas in 3 months post-op, child was on relapse, and after the radiotherapy, child went in remission, indicating the importance of clear monitoring in these patients. After about 7 months of the therapy with cortisol tapered, ultimately after 8 months, cortisol was stopped and child was only left on thyroxine. These are the anthropometric measurements which we did on follow-up visits. Clearly indicative when a primary pathology was treated, the weight subsequently went down and height, which was impaired due to high steroid levels, subsequently gained up. Currently, child is on close follow-up and only on tablet thyroxine. Child has lost 9 kgs of weight and feels physically well, but the child has certain psychological issues for which child is on follow-up psychiatrist, clearly indicating the role of cortisol in the psychological aspect. Elevated cortisol levels in the blood are associated with anxiety disorders, whereas low cortisol levels are indicative of depressive disorders. Hence, listening to the psychological aspect of child is also very necessary in addition to medications and surgery. Take home message: patient should be counseled about the chances of relapse at the start of treatment. Post-op cases of transphenoidal surgeries require continuous monitoring for relapse. Due to the varying levels of cortisol and stress of treatment, child may have certain psychiatric issues which should never be missed. Cushing should be managed with a multidisciplinary team consisting of pediatrician, pediatric endocrinologist, psychiatrist, radiation oncologist, and a neurosurgeon. That was the case which we wanted to present. This is the slide from before the child, from first visit to the last follow-up visit the child had.
Dr. Shivam, would you like to continue with this?
Yes, ma'am. Ma'am,
You can continue with this, and then followed by that there will be discussion.
okay. Good afternoon, everyone. I'll be sharing a brief note on Cushing syndrome. It is a clinical state of chronic glucocorticoid excess, and the incidence of Cushing disease is 1 in 1 million population.
We
We
can
can,
go slow.
yeah. And Any remarks from Dr. Saurabh Uppal or Dr. Ruma Deshpande, who is a consultant in pediatric endocrinology at Bharatiya Vidyapeeth? Any input on the case, ma'am, before we start the theory part of the Cushing's?
Oh yeah, just a moment.
Okay, fine.
So
Yeah.
yes, here we had a case who was obviously very obese,
Mhm.
uh, and it was kind of quite a. It was not a very difficult diagnosis, but I would like to say that all Cushing's, it's not so easy to diagnose them. This child was. I mean, we had all the hallmarks, and luckily for us, the biochemical diagnosis was also not that difficult. But we've seen certain cases where getting the diagnosis of Cushing's clinically they may appear and just behave like Cushing's, but however sometimes we don't get the biochemical diagnosis and where we have to go for further very sophisticated tests. So whatever Anshul has covered, it is a very straightforward. So just I would like to highlight that all cases of Cushing's may not be that easy to
That's
diagnose.
it.
I hope Dr. Saurabh agrees.
Yeah, yeah, I totally agree with you. But I think it's a good presentation to be done in this forum, and I would just like Dr. Anshul to overall tell
Yep.
everybody who's here
No.
as to what are the different pointers in your entire case where clinically you can pick up Cushing's. So, as Dr. Deshpande rightly said, biochemistry is not always that garden variety as you have shown in your case. It is actually very tricky for cortisol and ACTH. But your case is very good to present in this forum, and let's take this to inform everyone who's listening. What are the very classic clinical pointers in your case? There are three or four of them where when this combination comes, the clinician should suddenly become alert for Cushing's, or let's for say adrenal or endocrine problems.
Hmm.
Yes, sir. First of all, we have to look for anthropometry. That is a very first likely that will give a clue that it is a exogenous obesity or a endogenous obesity. The first and
Yes.
foremost endocrinal cause we will suspect is short and obese.
Yes. Perfect. Perfect. So whenever more mass is being accumulated with regard with as vis-a-vis the height, you have to be careful that there is an endocrine problem here. And because most of the obesity that will come to your OPD, children will be tall. So any obese child who's tall usually does not require an extensive workup. And any obese child who's not tall should be a red flag. That's one. Any other things you would like to discuss?
Second thing is the pointed towards increased insulin resistance and central fat in this child.
Yes. Okay. Fine. Yeah. You can look at that, but that's actually that's very confounding. So fat distribution is so when you know it's Cushing, you actually look at that fat. But in many of the very obese children, they would have this kind of a fat distribution and insulin resistance. Also, it's a very overlapping feature. But still, it is if you have insulin resistance and the child is not tall, then actually you're looking at something which is endocrine. That's the take home that we can take away from that. And there was another very important clinical feature that you mentioned.
Moon faces, sir. Dusky lips are connected.
Yes, and also for so whenever you are in a busy OPD, you cannot actually see a lot of things. So to everybody who's listening, you have an obese child, you think it doesn't look like the garden variety. Make them sit and get up from the floor. That is a quick measure to see proximal weakness. And if you have usually obese children, they will get up. But if you have significant proximal weakness, you are looking at endocrine etiology. Why I'm saying this is because cortisol and ACTH are very difficult to put a handle across. So that's another thing. And I think you had some mention about the alkaline phosphatase also in this, right?
ALP levels, no,
Yeah.
sir.
Oh, anyway, yeah. And there is a get to your first investigations. There was something very interesting there. Very interesting there. Yeah, lipids, and HOMA IR of 3.7, fasting insulin more. So
Yes.
how would you like everybody to take a message from these investigations?
So these HOMA indicators are a predictor of the amount of insulin resistance which is
Yes.
present in the body. It will
So
indicate since the central fat which is present around the portal vein, which is carrying the insulin from the GIT to liver, it is the fat which is
yeah.
related to insulin resistance.
Yes. So the message that everyone should take from this is, so you have an obese child with a raised insulin, with a raised HOMA IR. The first instinct could be that this is hyperinsulinemic obesity.
Yes.
But again, at the same time, your clinical vision should be, if the child has raised insulin, if the child is having insulin resistance, is this child tall? So if the child is not tall and you have a raised insulin, that means the what is it? What does insulin do? Insulin makes tissues grow. So
Yes.
when something is wants to make tissues grow, but the child is not gaining in height, you are looking at a endocrine diagnosis. So this is another pointer that immediately you should be alerted. I'm not looking at routine obesity. Why I'm emphasizing it again and again is that over the years I've seen that in a busy OPD, we are seeing so much obesity now. And with so much obesity, there are so many referrals wherein Cushing oid child. So you cannot investigate every child for Cushing syndrome. So this is another marker. And same with the lipid profile. You have a raised lipid profile, you have an obese child. Again, clinically, you can differentiate. I don't need to do anything if the child is tall. So that's what I wanted to bring across. It's a very complete presentation. Nothing that you have missed in it, just for the benefit of everyone. Yeah.
And before examination, history taking, dietary
Yes.
history.
Yes. Definitely. Definitely. Hmm.
Anything Ruma ma'am would like to say?
I think, yeah, as you know, obesity has become so common. So the only hallmark here is, the investigations are also going in favor of nutritional, but it is the height of section which is the catch in this case. So, um, so I think I would again like to highlight the same thing.
Yeah.
Who is
And
yes,
And Dr. Ruma would agree with me. Moon faces, buffalo hump. You see this a lot in routine obesity. So
yes.
it is a lot in routine obesity. So yeah,
Absolutely. Yes.
yeah,
And as you said, the proximal muscle weakness, very
yeah,
sensitive sign, very
yeah.
sensitive.
Very sensitive sign. Just
Yes.
make them sit down and get up.
Yes. And this
Yeah.
case of fracture, in this case, we thought probably, it must have been ongoing. So we don't
Hmm.
really know whether we could, attribute the fracture to the, poor bone mass due to the,
Yes.
but still, that's an important history which we thought we should include in the,
Yes.
past history.
Yes.
Dr.
And
Anshul,
it's
what is Cushing syndrome and Cushing disease? Do a general pediatrician should use these terms synonymously? And another thing, pituitary microadenoma or macroadenoma are usually very common finding. How much of the cases are actually pathological? What is your take? Did you do any literature review about that?
Yes, ma'am. Usually, there is a big difference between Cushing syndrome and disease. In Cushing syndrome, the primary we are saying that there is a state of increased glucocorticoid
Mhm.
excess. The cause can be due to adrenal excess. That is, the adrenal glands are only autonomously producing increased amount of glucocorticoid. It also includes the exogenous source, whether small eye drops, even topical skin ointment when applied to break skin parts can cause Cushingoid-like features. Whereas Cushing disease is a specific term which we use when the adrenals are producing excessive glucocorticoids in response to increased ACTH.
Excellent. And how
And
much adenomas, micro or macroadenoma, actually are pathological?
uh, we label based on dimension. Less than 5 mm, we indicate microadenoma. More than 5
Mhm.
mm, we indicate macroadenoma. The
Yes.
treatment usually macroadenomas causes space occupying lesions. They mainly present with raised ICT signs, whereas microadenomas are diagnosed when they are actually excessively functional. Otherwise, a microadenoma which is not, we had a similar case. A girl came with all such features, But when we checked, we did a MRI. MRI indicated a microadenoma, but the child had no biochemistry profile of cortisol and ECTH elevated. Indicated that microadenoma was just a extra
Mhm.
finding which we got in MRI. So
Yes,
not every
excellent.
microadenoma we have to treat.
Very good. Excellent,
Microadenoma
excellent.
causing
This
the
is the
disease
this is the
has to be
message
treated.
because this is very incidental finding like
Yes,
हाँ
incident.
some
Yes.
arachnoid
See,
cyst. Now people are very
no,
scared कि oh my God कुछ
no. See, the
गांठ आ
problem
गई.
is that these
Uh,
days the MRI machines are so good
3 Tesla that.
that the altered signal intensity many times is picked up as a microadenoma.
Mhm.
Now it is so there is so what you need to do immediately if you have see if you have a radiologist who's very enthusiastic and because of the machine's high resolution is given a microadenoma, you do tell them do a dynamic contrast. In a
Mhm.
dynamic contrast, you can actually many times there's just a signal intensity. It is not a microadenoma because
Dr. Rahul Jahangir, HOD Bharti Vidyapeeth, sir has joined. Any comments from on your side? I think Dr. Uppal's network issue is there. Dr. Rahul Jahangir, sir.
Madam, I just joined. I was a bit busy. Sorry,
No,
I
no
just joined
issues.
late.
Welcome, sir.
You could please
Welcome.
continue. I'll comment a bit later.
Case has been concluded, sir.
Okay. No, it was just a very interesting case which we
Okay,
could
fine.
manage successfully. Hence, our intention was to make others aware of our
Yeah.
interventions and how it can help children.
Thank you.
Um,
Thank you so
like
much for the
people said,
case.
Cushing's is a bit difficult case to diagnose as well as manage.
Yes, sir.
So it was just for people's awareness that we wanted this to be presented on the forum. And thank you so much for your kind support and permission to allow us to do this. And thank you so much.
Thank you, sir, for sparing your time and sparing your team for this excellent case presentation. Dr. Saurabh Uppal, your net was gone, I think. Yeah, yeah, please, please.
yeah. So I don't know till what time you could hear me because I just got logged
We
out.
can hear you like infinite time. Please continue. There is
No,
no.
no, 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 no. I just wanted to say that you should have a dynamic contrast and maybe take an opinion and go with the clinical pointer. If you have a macroadenoma, then the picture is very clear. But in a microadenoma, many times it's a diagnostic overkill. So clinically, if you don't have endocrine markers, you should just evaluate with a follow-up of MRI at a good center with a good radiologist. That's what the message is. Yeah.
I would like to just add one more clinical pointer in this case. This child had, subtle hyperpigmentation of the lips, and we could just make out that this child was hyperpigmented.
Mhm.
So this finding could, help us make a
So,
differentiate.
Pranshul, if you have pic of that, just ma'am is highlighting, no? Just show in the meanwhile so that the audience will correlate. Yeah, if you have clicked. Yeah.
So he had dusky lips and conjunctiva. So
Mhm.
in the setting of suspicion of Cushing's, when there is hyperpigmentation, then we can say that probably it is Cushing's disease, pituitary Cushing's,
Yes.
compared to adrenal Cushing's or this syndrome. Because in pituitary Cushing's, we expect hyperpigmentation to be there because of the raised ACTH. So this was just one fine clinical pointer I thought.
That's a very important and it's a golden sign to actually see that it is significant. Yeah. Thank you very much.
You've used the term Z scores in DEXA scan. Are there any T scores also?
Yes, ma'am. A T-score is a standardized term which we mainly use in cases of adult because it compares the Z-scores of children to a 50-year-old standardized female and male. So we can't compare as we know the DEXA values are changed by the height, pubertal status, and many other factors. So Z scores are that for that same age. So that's why DEXA we usually do beyond 5 years, after which the Z scores are available. We usually don't label osteoporosis in child based on T scores because it is a reference value of a 50-year-old female or a male.
All right. Any conditions less than 5 years of age where you would like to do DEXA
Yes, ma'am.
for
Like in osteoporosis or other low bone mass causes like Ehlers-Danlos, OI, osteogenesis imperfecta, in which there are repetitive low impact fracture. We label as low impact fracture when the child has fallen from less than 10 meter or less than the height of the child himself. Then we label that trauma as low impact trauma. If the child has came with the repetitive fractures with that, then we can go for a DEXA to look for peak bone mass in that child, aerial bone mass.
All right, good. Dr. Seema, shall we continue with Dr. Anshul or shall we give over to Dr. Shivam?
And Dr. Shivam can take over.
Good afternoon, everyone. I'll be sharing a brief note on Cushing syndrome. Cushing,
And you will be slow.
yes, ma'am. Cushing syndrome, it is a clinical state of chronic glucocorticoid excess, and the incidence of Cushing disease is 1 in 1 million population. The most common overall cause of Cushing syndrome is exogenous glucocorticoid intake. Most common endogenous cause in children more than 7 years is Cushing disease, that is pituitary ACTH adenoma per se, and in less than 7 years or in infancy, it is adrenal tumors predominantly. In infancy, it is usually McCune-Albright syndrome, which is the most common cause of Cushing syndrome. And the further causes of Cushing syndrome are ACTH dependent and ACTH independent. ACTH dependent, the further causes are Cushing syndrome, as I said, pituitary microadenoma that is less than 5 mm, and ectopic ACTH that is common in men1, multiple endocrinal neoplasia and Rett syndrome. And the ACTH independent, it is the adrenal adenoma, which is benign cortisol secreting tumor, adrenal carcinoma, which is an aggressive course, adrenal hyperplasia, McCune-Albright syndrome, which is caused by GNAS mutation. GNAS, it is a gene which codes for G protein, that is GS alpha, and which is required for the ACTH receptor signaling. And it has an early onset, as I earlier mentioned. It is most commonly seen in the infancy. And the exogenous causes most commonly are the prolonged steroid therapy. The clinical features of Cushing syndrome are weight gain, and how we can differentiate it from the simple obesity. It is a growth failure, and in obesity, the child will be taller. However, in Cushing syndrome, the height will be slightly on the shorter side. The other features are weight gain, growth failure, hypertension, delayed puberty, acne, hirsutism, moon faces, buffalo hump, that is a late sign, stry, bruising, and low bone mass. And as sir mentioned, there can be low impact fractures, can be indicator of low bone mass. Psychologically, the child can have compulsive behavior, as in this case, the child was on psychiatric follow-up and emotional ability. The diagnostic, the screening tests are, as we all know, that cortisol, the highest amount of cortisol is in the morning, 8 a.m. And then in the midnight, it decreases by about 50%. And in the earliest sign of the Cushing syndrome can be loss of circadian rhythm. However, the further diagnostic and the screening tests are 24 hours urinary free cortisol. Normally, the value is less than 70 microgram per meter square per day. Midnight cortisol, normally it is less than 1.8 microgram per deciliter. Late night salivary cortisol, the cutoff value for which is more than 1.45 nanogram per ml. And how we can differentiate between simple obesity and Cushing syndrome is, in simple obesity, or urinary cortisol levels are also higher, but in that the salivary cortisol levels are lower, which in Cushing syndrome salivary cortisol levels are elevated. And then further, we can see the ACTH levels. It is high in ACTH dependent causes like Cushing disease, and low in the adrenal causes, non ACTH dependent. The dexamethasone suppression test, it is further of three types. Overnight dexamethasone suppression test, the dose is about 15 microgram per kg, maximum ceiling up to 1 mg. Should be given at 11 p.m. And then we measure the cortisol level at 8 a.m. If it is less than 1.8 microgram per deciliter, it is normally suppressed. And if there is no suppression, then we can have a suspicion of Cushing's syndrome. And then the other test is low dose DEXA, and there is high dose DEXA. Low dose DEXA, the dose is zero point 0.5 milligram 6 hourly for 2 days, and the high dose DEXA test, there is the dose is 2 milligram 6 hourly for 2 days. And the interpretation of the low dose DEXA is, if the cortisol is less than 1.8 microgram per deciliter, it excludes Cushing syndrome. However, if there is no suppression, we can have a diagnosis of Cushing disease, Cushing syndrome. In high dose DEXA, it is used to differentiate between the ACTH dependent, that is the central causes, versus the non ACTH dependent peripheral causes. And the dose is 2 milligram of oral DEXA 6 hourly. And if there is suppression of the cortisol levels, we are dealing with the Cushing disease, that is the primary cause in the pituitary adenoma. Or if there is no suppression, then there is a non ACTH dependent causes. Bilateral inferior petrosal sinus sampling in cases in which no cause could be identified. Bilateral inferior petrosal sinus sampling can be done to lateralize tumor or differentiate cause of ACTH. Baseline ACTH, the central to peripheral ratio is more than 2 is to 1, and the post CRH, that is the CRH stimulation test, that is the ACTH ratio central to peripheral is more than 3 is to 1. The treatment options in the Cushing disease, that is the pituitary microadenoma, the first line is the transsphenoidal surgery, and the second line is the radiotherapy. And in the adrenal causes, we can simply do the surgical removal of the adenomas or the carcinoma of the adrenal gland. And in the medical treatment, that is a temporary transient treatment, we can have cyproheptadine, that is the central serotonin antagonist that suppresses the ACTH levels. Uh, Other than that, we can cause adrenal steroidogenesis inhibition, that is caused by ketoconazole, etomidate, metapon. And after that, in adults, we also use pasireotide, that is a somatostatin analog, which suppresses the ACTH levels. And the exogenously, if it is caused by increased intake of steroids, we can do gradual steroid withdrawal. In the previous case, that was we opted for radiotherapy versus repeat surgery. The repeat surgery, the advantages are it causes rapid normalization of cortisol level, and as it addresses the primary pathology. And the surgery is opted where there is discrete pathology is there. And in cases of diffuse pathology, we can opt for radiotherapy. However, the limitation and the risk of surgery are CSF leak, diabetes insipidus, hypopituitarism. And the repeat surgery is difficult per se, as we have to deal with the scar tissue and the distorted anatomy. Radiotherapy, the advantages are that it we can avoid the repeat surgical morbidity. It has a long-term effective control, and it is useful in the diffuse disease where we cannot uh, localize a single pathology. However, the disadvantages it has a delayed onset of action, and it is not suitable for acute control, hypopituitarism, and when there is a progressive loss of pituitary hormones. Thank you.
So I would like Dr. Shivam or Dr. Anshul to guide me if I was a parent of a 13-year-old child, and I was thinking that this child is a case of MAFLD, not a Cushing disease. So, what is the advice you are going to give to a parent who is a case of obesity with MAFLD, or who is a case of obesity with Cushing disease?
Uh, First of all, ma'am, NFLD we will label when in on the ultrasound more than 5% of fat will be there in the liver. In case of NFLD, as we know, the primary pathology is due to the defective lifestyle. So first and all, we have to do the corrective lifestyle modifications, which may include both dietary and both exercise. Alone dietary modification won't work, alone exercise won't work. Both have to be undertaken simultaneously. Lifestyle modification, we in general advise the child to do 30 to 60 minutes of moderate to vigorous activity. We usually describe that an activity should be of such level that the child develops certain amount of breathlessness and sweating. Not a simple mere walking would help in weight loss. Whereas in case of small lifestyle changes like using stairs instead of escalators, using cycling, or you go by walking in school rather than using buses. Secondly, on dietary modifications, we advise a high fiber and a high protein diet and a low carbohydrate and low fat diet.
And in a case of a, a parent is sort of confused that what to do
In
in a
case of Cushing's. In case of obesity due to Cushing's, we have to be cautious first of all in relation to the exercise part. As if we prescribe a high intensity exercise part, it can be harmful for the child also, as the bone mass is reduced, and moreover the child is overall in catabolic state, due to which the growth is also affected. So certain dietary part remains the same, but the primary modality will be on the close follow-up monitoring along with the lifestyle modifications.
All right. And how long this child should continue on thyroxine?
Ma'am, as told, thyroxine deficiencies, this child can be due to three scenarios. Either increased cortisol levels were only suppressing the TSH, either the tumor cells have damaged the thyroid cells, and the third probability that the central hypothyroidism developed post-operatively. But in our child, the probability was of the first two scenarios. But if the TSH was low due to the elevated cortisol levels, it would have spontaneously reduced, and thyronome doses would have been reduced on follow-up visits. But the thyroid is continuously the child is requiring for thyroxine, so maybe the tumor has damaged the thyroid cells of the pituitary. So child will require a long time thyroid treatment.
Any recommendations on calcium and vitamin D in this child,
Yes, ma'am.
along with the
Yes, ma'am. As the ma'am cortisol levels suppress 1 alpha hydroxylase in the renal part, so definitely this child will need a daily vitamin D and calcium supplementation.
any dietary modification for hypertension as a common parent's concern?
Ma'am, for hypertension, we will advise a DASH diet, that is a low salt diet and a high protein and high fiber diet.
What is the salt intake you are advising? कैसे बताएं उनको कि कितने चम्मच डालो,
Yes.
खाना कैसे बनाओ?
Ma'am, shortly, we can't say that stop using even a minuscule of salt in diet. We can just prescribe that the amount of salt they are using has to be reduced overall in all forms of diets. Like in breakfast and dinner, everything. Like if they were prescribing 2 spoons a spoon, they can reduce it to 1 or 1.5, as the sodium is required. No added salt.
Thank you. Doctor, over to Dr. Seema.
Thank you, ma'am, for the excellent concluding of the case. And I extend my thanks to Dr. Saurabh Uppal, Dr. Uma, Dr. Rahul Jahan Girdhar, sir, for showing us an excellent presentation and a management and overall improvement of that patient who presented at your setup with Cushing's disease. Any comments from Dr. Gurpreet? Dr. Gursharan Singh Narang, sir? Any comments from Dr. Radha Bansal, our EB, very dynamic, attends all meetings of SAPA. Dr. Radha?
Very well discussed. So I don't think it needs any more dedication from my side. Thank you so much.
Okay, thank you. Narang, sir, are you there?
Hello.
Yeah, Hanji, sir.
जी.
Any concluding remarks from your side, sir?
It was a very nice presentation, Dr. Uppal.
No, it was very
Any
nice presentation.
suggestions from you?
No, Dr. Anshul, it was a very good case, very well selected case for presentation. There were a lot of learning points, and the discussion has been steered very well by everyone, including Dr. Bajinder ma'am. Very important points discussed and extracted from the presentation. So I think everything has been taken care of.
What I feel basically for all the speaking broadly for all endocrine cases, they generally reach late at the right place in general.
Yes, sir.
Yes.
More and more awareness is required, not only for this case, for almost all the cases related to endocrine.
Yes, we need to enable more clinical pickups so that
Correct.
because it is a deficiency on everyone's part. We all need to work harder. We need to provide more clinical oriented pickups to the grassroots practitioners so that they can be picked up in time. So the responsibility is on all of us to ensure that they reach the right place in time. Yeah.
So I agree, and team
Proper
networking will, yeah,
proper
definitely help.
history taking, examination, and if the facility is not available with us for some investigation, then rightly referral should be done.
Correct.
From I can do to we can do a team networking
Yes.
and
Yes.
give and take, and especially when you send your patient to tertiary level care, no, the feedback to the first, like the first handle pediatrician should always be there. Yesterday, I
Yes.
went to state consultative meeting of childhood cancer, CAN kids. So I was quite taken aback that time to reach at tertiary level of care for childhood cancer, 1 year for Hodgkin lymphoma, 2 to 3 months for Lukes, where the you can see staging and all that matters a lot. It's a life and death matter for them. So yes, team networking, maybe such case presentation, and will definitely help in improving the overall outcome of a child in all aspects.
And
Any
I
other
must
from?
congratulate the team for having this regular case presentations, and because this actually empowers everyone. So my congratulations to the team. It's been a very regular thing, so it must be carried on. It takes a lot of hard work. It's like, it goes without saying.
Thank you so much, everyone. Okay, any final comments, questions? Otherwise, we'll conclude. Anyone from your side, Dr. Ruma? Yeah.
Thank you very much for this opportunity.
Thank you so much, everyone. Thank you.
Well done, Dr. Anshu.
Excellent case presentation.